Let's start with a scenario literally every single one of us has seen. You walk into the exam room and there's an elderly patient waiting.
Right.
Maybe they're 78, maybe 82, and they are just in absolute agony with severe knee osteoarthritis.
Yeah, they can barely walk to the mailbox.
Exactly. Their sleep is disrupted, their quality of life is visibly shrinking, and you, as the clinician, are staring down a binary choice that feels incredibly heavy.
It really is. It's the classic fork in the road.
Hmm.
Do we recommend early total knee arthroplasty? I mean, do we pull the trigger, fix the mechanics, and hope for relief?
Or do we hold the line?
Exactly. Do we stick with prolonged conservative management? It sounds like a simple choice between action and inaction, but physiologically, the stakes are just massive.
They really are, and that is exactly what we are unpacking today. It's that tension between the promise of a surgical fix and the reality of putting a geriatric body through major orthopedic trauma.
Because on one hand, surgery offers that quote-unquote cure we all instinctively want to provide.
Right, we want to fix the problem.
We do. Yeah. But on the other hand, we know the risks in this specific demographic aren't trivial. They're real.
And I think for a lot of clinicians, this decision often comes down to a gut feeling or honestly just institutional habit. But today, the mission is to move beyond that gut check.
We have to. We need to establish a logical, evidence-based decision framework for you to use in clinic.
Exactly. When is the risk of surgery actually justified? And when is conservative care the more aggressive, protective move?
So let's start with the baseline. If you look at practice patterns, the vast majority of clinicians, when faced with that elderly patient we just described, they will instinctively lean toward conservative management first.
Right. Physical therapy, NSAIDs,
Right.
injections.
Yeah, all of that.
Yeah.
And why is that the default posture? It comes down to the most fundamental principle we have, which is safety.
It's the safe harbor.
It is a safe harbor. Conservative management avoids the acute, immediate dangers of the operating room. We aren't introducing the risk of venous thromboembolism or infection or cardiac events.
The things that come with anesthesia and surgical trauma. It's the path of least resistance, but in a good way. It's the path of least harm.
Precisely. And we have to look at the data regarding what I call the moderate benefit versus moderate harm trade-off. This is crucial for your risk-benefit analysis.
Okay, let's break that down.
So the evidence suggests that while early surgery does offer better pain relief compared to conservative care, that benefit is classified as moderate.
Just moderate.
Just moderate. It is not infinite, it's moderate.
That's a really specific and important classification because I think a lot of patients and maybe even some providers subconsciously expect total benefit.
Oh, absolutely.
Like we're going to swap out the parts and they'll be walking like they did in their 40s.
And that expectation gap is where the trouble starts. We aren't reversing aging. We are mechanically resurfacing a joint.
Right.
The data shows that while function improves, it rarely returns to a pre-disease baseline in this age group. So you have a moderate upside. Now flip the coin. What's the downside?
A harm profile.
Exactly. The harm is also classified as moderate. But we really need to contextualize that.
Because moderate harm means something very different depending on who you're talking about.
Exactly. Moderate harm in a healthy 50-year-old might mean a superficial wound infection or a longer course of PT.
Which is annoying but manageable.
Right. But moderate harm in an 80-year-old is a very different animal. We're talking about post-operative delirium, decompensation of underlying heart failure, urinary retention.
Or a cascade of frailty that they just never quite recover from.
That is the key distinction. In a geriatric patient, a moderate complication can easily trigger a systemic spiral.
Right. So if the benefit is moderate and the risk is real and potentially systemic, the logical default has to be conservative care.
You are prioritizing patient survivability and systemic stability while still attempting to manage the symptoms.
It's about not rocking the boat unless the boat is already sinking.
That's a great way to put it.
So if the scale is balanced between moderate benefit and moderate harm, the tie goes to the non-surgical option. That makes sense.
It does.
But we also know that for some patients, safety just feels like prolonged suffering. There is a breaking point where that default posture fails.
And that is the hardest part of the curve for us to identify. The default breaks down when the conservative instinct turns into a neglect of the patient's reality.
We have to define refractory very carefully here, because refractory doesn't just mean it still hurts.
Correct. True refractory pain means the patient has undergone optimized conservative care. And I really want to stress the word optimized.
Right, this isn't just passive waiting.
It isn't just telling them to lose weight and take Tylenol once a day. It's active management.
So what does that look like?
Have they had a dedicated course of physical therapy focused on strengthening and range of motion? Have we utilized multimodal pharmacotherapy like topical NSAIDs?
Maybe intra-articular injections, corticosteroids, hyaluronic acid.
Exactly. Have we addressed gait aids? If we haven't thrown the kitchen sink at the non-surgical plan, we simply cannot call it refractory.
That's a great checklist. You essentially have to earn the right to consider surgery by exhausting the non-surgical options first.
Precisely. But let's say you've done all that. You've optimized the care, and despite all that effort, they still have severe functionally limiting pain.
That's the pivot point.
That is where the calculus shifts.
Because now the safe harbor isn't actually safe anymore, it's just miserable.
Exactly. When the suffering is high and the conservative options are truly exhausted, the risk of surgery becomes an acceptable trade-off.
We are trading the safety of the status quo for the potential of quality of life improvement.
But you only make that trade if the current quality of life is untenable.
Okay, so we've established the when, that moment when optimized care fails. Now let's talk about the who.
This is critical.
Because not every 80-year-old is created equal. We talk a lot about physiological versus chronological age. How do you stratify this in the clinic?
This is probably the most critical variable. We tend to group the elderly into one big bucket, but the data suggests a significant split around the age of 80. Let's call them the younger elderly, those under 80, and the octogenarians.
Let's look at the under 80s first.
For patients under 80 who have few comorbidities, they are often excellent candidates for early arthroplasty. Their physiological reserve is usually high enough to handle the insult of surgery.
So in this group, if the pain is there, the hesitation to operate should be a bit lower.
Right, because their bodies can still bounce back. They have the metabolic headroom to handle the stress of anesthesia and blood loss.
But once they cross that 80-year threshold, the needle moves.
It moves significantly. The octogenarians face a statistically higher risk of surgical and medical complications. Even if it looked great for their age, their homeostatic reserve is simply lower.
The margin for error is thinner.
Much thinner.
It's like walking a tightrope. At 70, the rope is wide. At 85, it's razor thin. A minor complication that a younger patient shrugs off can send an octogenarian straight into the ICU.
Exactly. In this group, the over 80s, the default to conservative care should be much, much stronger. You need a very compelling reason to operate on an 85-year-old compared to a 70-year-old.
The burden of proof is just higher.
It has to be.
And obviously, age is just the headline. The fine print is the comorbidities.
Absolutely. We're looking at ASA scores, cardiac history.
The ASA classification is a great shorthand for this.
It really is. If a patient has significant cardiac disease, uncontrolled diabetes, or renal issues, essentially ASA class 3 or 4, the operative risk skyrockets.
A high ASA score should essentially halt the surgical conversation unless it's an emergency.
An elective knee replacement is almost never an emergency.
Never.
And it's interesting because sometimes as musculoskeletal specialists, we get tunnel vision. The knee is the loudest thing in the room.
It's the thing screaming for attention.
But the heart is the most dangerous thing in the room.
That is the perfect mantra. We can fix the knee perfectly, beautiful alignment, great range of motion on the table. But if the heart gives out during recovery or the kidneys shut down, we haven't helped the patient.
We've hurt them. We have to treat the whole patient, not just the joint.
Which brings us to functional status. Because pain is subjective, but function is objective.
Right. It's not just about a pain score on a scale of 1 to 10. It's about impairment. Is the knee preventing them from doing the things that make life worth living? Or is it just annoying?
That's a harsh question, but a necessary one to ask.
It is. Are they housebound because of the knee? Can they not get to the bathroom independently?
Or can they still get around the grocery store, but they're just sore afterwards?
Exactly. The level of functional loss needs to justify the surgical risk. If they are sitting on the couch most of the day anyway, the functional gain from surgery might be minimal.
But the risk remains high. So
Exactly.
you're looking for a mismatch between their desired activity level and their current ability.
Right. If the knee is the only thing stopping them from being active, that's a point for surgery. But if they are limited by heart failure or COPD, fixing the knee won't suddenly make them run marathons.
Now I want to pivot to the traps. The things that trip us up in practice.
Yeah.
Because even seasoned clinicians can get lured into making the wrong call here.
Oh, absolutely.
What would you say is the biggest red herring in this decision-making process?
Without a doubt, it is the X-ray. We call it the X-ray trap.
I think we've all been there. You put the film up on the light box or pull it up on the screen, and it just looks like a disaster zone.
Bone-on-bone osteophytes everywhere, subchondral cysts.
And you immediately think, well, obviously this needs surgery.
And that is a dangerous assumption. One of the most consistent findings in orthopedic literature is that radiographic severity does not correlate perfectly with symptom severity.
You can have a patient with a horrific X-ray who actually has manageable pain and decent function.
And vice versa.
Yeah.
But the trap is treating the image. If you operate on the X-ray, you are exposing the patient to all that risk for a problem that might not actually be bothering them as much as the image suggests.
So the rule is treat the patient, not the picture.
Always. If the symptoms and the functional impairment don't match the image, do not proceed. The symptoms have to drive the bus.
The X-ray is just the map. It tells you what is wrong anatomically, but not how it's affecting the patient's life.
Exactly.
Another pitfall I see a lot is what we might call the extrapolation error.
Yes, this is a big one.
We see data from younger populations, 60-year-olds getting knees done, playing pickleball 6 weeks later, and we subconsciously apply that expectation to the geriatric population.
And that is a fundamental error in logic. The risk profile of a 65-year-old is fundamentally different from an 85-year-old.
You cannot extrapolate the success rates and low complication rates from a mixed age or younger population and just apply them to the frail elderly.
The biology is different. The recovery curve is different. And the resilience is different. We have to look at the evidence specific to this demographic.
Right, and when you isolate the data for the very elderly, the complication rates tick up significantly.
We simply can't sell an 85-year-old the results of a 60-year-old.
And we also have to be honest about institutional biases. We all work in systems, and sometimes those systems prioritize volume or efficiency.
It's the unspoken pressure, availability bias. We have an open slot on Tuesday.
Or institutional incentives to keep surgical volume up.
It is much faster to book a surgery than it is to have a 20-minute conversation about why we shouldn't do surgery and explain the nuances of conservative care.
That's a profound point. Conservative care takes more time to explain than surgery does to schedule.
It does. But those pressures must never, ever drive the clinical decision. The decision has to be insulated within the patient-physician relationship.
We have to be the firewall against those systemic pressures.
Exactly. We are the firewall.
And one more trap I want to mention is short-termism, focusing only on the immediate relief.
Right. We focus on that 6-week post-op pain score. Look, the knee pain is gone.
But we forget to factor in the long-tail risks, the delirium that might persist for months, the rehabilitation struggles that might leave them weaker than before.
Or the potential for revision down the road, or the impact of a complication on their overall frailty.
You have to play the long game. You have to ask, where will this patient be in 1 year, not just 1 month?
Exactly.
Let's talk about the evidence itself for a minute, because when you actually dig into the literature on this specific comparison, early arthroplasty versus conservative care in the elderly, it's not as clear-cut as we might like.
It's definitely a gray zone. We have to be completely transparent about managing uncertainty here.
The evidence is largely indirect.
Yes. We don't have massive, definitive, randomized controlled trials that specifically compare early surgery versus prolonged conservative management exclusively in this geriatric demographic.
So we're triangulating.
We are. We are inferring from broader studies and safety data. That means we can feel moderately confident in the conservative first approach, but we cannot be dogmatic.
We can't say science proves you should never operate.
Right. We are operating in a space that requires individualized clinical judgment, not robotic adherence to a protocol.
Which brings us to the final and perhaps most important variable in all of this, the patient.
Because if the science is gray, the patient's values have to provide the color.
The patient's voice is the tiebreaker. This is the essence of shared decision-making. We aren't just mechanics fixing a car, we are partners.
And this is where informed consent stops being a form you sign and starts being a real process.
So let's say you have a patient who understands the risks. You've laid out the moderate harm potential.
You've explained that rehab will be tough, likely tougher than they imagine.
You've been brutally honest about the delirium risk, and they still say, "Doc, I can't live like this. I want the surgery."
If that patient is well-informed and, truly understands the risks, not just nodding along to get it over with, and they strongly favor the potential relief,
Mhm.
then early arthroplasty is reasonable.
Their risk tolerance is a valid clinical variable.
Their willingness to gamble is part of the data set.
It is. If they value the chance of mobility over the risk of complication, that is their right.
But we have to ensure they aren't basing that on false hope.
And the converse is true, right? The risk-averse patient.
Absolutely. If you have a patient who is terrified of surgery or who prioritizes independence and staying out of the hospital above all else, that aligns perfectly with the medical evidence supporting conservative care.
You should never talk a reluctant elderly patient into an elective joint replacement.
Never. If they are hesitant, that is a massive red flag. The rehab requires buy-in.
If they aren't bought in before the surgery, they won't do the work after, and the outcome will be poor.
Exactly.
So let's try to synthesize all of this. We've covered the safety profile, the pivot points, the pitfalls, and the patient values.
We covered a lot of ground.
If you had to boil this down to a golden rule for the listener to take back to clinic tomorrow, what is it?
The rule is this. In elderly patients with severe knee osteoarthritis, your default posture should always be prolonged, optimized conservative management. Stick to the safe harbor.
Unless,
And here are the three conditions. Unless there are severe refractory symptoms despite optimized care, there is an acceptable surgical risk profile regarding comorbidities, and there is a strong informed patient preference for intervention.
you need all three to justify the deviation.
You need all three. Refractory symptoms, acceptable risk, strong preference. That's the triad.
Triad. If you have those, you can operate with confidence. If you're missing one, you hold the line.
Hold the line.
That is a remarkably solid framework. It really takes the guesswork out. Before we wrap up, I want to leave the listeners with a final thought to chew on. We talked earlier about physiological age.
Yes. I want to challenge everyone listening to look beyond the birth year on the chart.
We get so fixated on the number 80 or 85.
But the next time you're in that room, look at the biological resilience of the patient in front of you. I've met 80-year-olds who are frailer than 90-year-olds and 70-year-olds who have the physiology of a 50-year-old.
The chart tells you how long they've been alive.
Yeah.
Your clinical exam and your